We are going to start from a therapy point of view, looking at the early detection of developmental delays in children. And I'm sure many of you are familiar with what we call the pyramid of learning, which is really a culmination of the complexities and the different levels that we deal with when we speak about development in childhood. And many years ago, it looked like this. And then a few years later, it changed into this, where especially on a sensory level, the sense of interoception was added. But we are very aware that the current status, we are looking at the pyramid of learning in this way, where it is really a far more complex process. And if I say complex, detailed, there's far more a detailed approach to looking at the pyramid of learning. And also, as clinicians from different areas of allied health, of course, we are not all specialized on all these different levels of development. And we will also look a little bit later on how these areas that we are all specialized in can complement one another. I want us to look a little bit from a therapy perspective through the different lenses that are very important to us. So the development itself is one aspect, one thing. However, we never look only at development in isolation. And I'm sure all of you are very familiar with, oh, sorry, I skipped one a few too fast now. The first lens is the World Health Organization's International Classification for Function and Disability. This almost, I want to refer to, is our foundational perspective. And if we look at this, we also know that the reason why we do therapy lies at the level of participation. And as a build up to there, we focus a lot on the autonomic nervous system, a sense of safety, how we socially engage, sound sleeping and eating habits, socialization with others, play, and the ability to learn and educate. So all of those are very important when we work with children to get them to a level of what we call functional participation. So we do not only look at the health condition, we do not only look at the body structures, the body functions, we do not only look at what can we do with those parts of our body, but we actually look at how do we functionally apply that and participate into life. And of course, all of this takes place also with the background of the environment and the personal factors. Another lens that we always have part as, or yeah, which is part of the path or the journey when we work with children, is the whole question, is it development we look at? Do we need a diagnosis? And of course, as allied health professionals, it's extremely important for us to have a diagnosis especially when there are risk factors and precautions that we need to take into consideration. The question is, however, should we wait for that diagnosis? And we work with a lot of parents who say, yes, but the pediatrician said, let's wait a bit, or this or that medical specialist said, no, let's wait until this or that age. But I'm sure you will agree with me that it doesn't really matter. Of course, we will work with care if there is no medical diagnosis. However, when we do look at development, we would prefer to look where are the gaps in development as soon as possible so that we can immediately start with our intervention. And we also know that once therapy or intervention has started, that may actually contribute to making a more accurate diagnosis. So again, some of you may have seen this slide before. When we look at, we take the metaphor as development as a pyramid or learning of skills. The pyramid, if you look at those skills where the body structures are involved, we develop skills as one pyramid, and you look at the family, the context, the personal factors of the child as the other pyramid, there's a little upside down triangle in the middle. And the idea of that is to say when the child is little, when we're still in a foundational stage, these gaps are small. So the longer we wait, the bigger that gap becomes. And that, of course, is complicating the process of early intervention, early detection intervention, more than what it should be or can be. Another important factor here is habilitation. You know, we are often very excited, as we should be, about neuroplasticity. However, there's also research indicating that neuroplasticity does not equal simplicity, because when you work with an adult, you worked with a fully developed system, physically, mentally, emotionally. So when a skill is lost, it's easier to adjust to the lost skill because you've got a very rich memory bank to work from. However, we know when we work with children, it's a very dynamic process. The development of skills are happening at the same time that our interventions are trying to catch up on lost skills or underdeveloped. Depending on the complexity of the case as well, it can become more complex than a simple use of neuroplasticity. Another lens that as therapists we look through is the age transitions of children. And I'm sure you are all familiar with this, and it's very important to understand that the brain operates fundamentally different in each of these stages. Our next lens is, of course, family-centered care, where we know it's a journey where the child is inside of the vehicle of the family. The process of intervention is often looked at as the journey, and there are many different parts that work together when it comes to family approaches. Value-based rehabilitation is a more recent concept that has an impact on our early detection. And it's contributed mostly, the research from that is contributed mostly from underdeveloped countries. But it boils down to what is the best value for money and for time when you work with children, when you work with rehabilitation in general, but especially with children, it's very important to know that the best value based pediatrics is your specialized clinicians. And it is truly based on the previous mentioned fact of the complexity and the dynamic nature of development. So the dedicated interdisciplinary team making use of pediatric technology and again family-centered care, and then also life care planning, which is often needed for children. Teamwork. I'm also familiar with the multidisciplinary approach, the interdisciplinary approach, and the transdisciplinary approach, the latter of which the parents are also far more involved and the team is far more overlapping. An interdisciplinary approach is probably the most commonly used one in pediatrics, where we work together in a coordinated intervention. And then, of course, I am 100% sure that all of us are leaning into the early intervention, which is another lens where we really aim to promote the child's health and well-being, enhancing the emergence of competency, minimizing the gaps, remediate, prevent deterioration, and promote adaptive parenting, which again is part of the more complex nature of the work that we do. Early intervention is then very sensory motor based, attention regulation, relationships, and leans heavily on therapy support. Again, when we look, the model of early intervention also looks at environmental enrichment, responsive parenting, focused on attention, regulation, relationships, communication, maternal sensitivity to the infant behavior and cues, sensory development, and motor learning, where we really work on active scaffolding. It's also interesting to note that this is also the order of priority that an early intervention smart clinical reasoning model learn into. I also like to use this metaphor where when we look at early intervention team and the parents being part of the team, that we also look at the parent as the expert. The parent really do know the child much better than any of us will know the child. And of course, they're an active decision maker. And then we, as the clinical team, we are the experts on that condition or that hurdle in the process of development. And the teacher is really the child, his neurological capacities, and the neurological capacities of the child also often determines the speed at which the intervention can go ahead. The second last lens is the autonomic nervous system and the polyvagal theory. This is a later theory, although it developed early or in the mid-19s. There's a lot of emphasis recently on the application of this theory into our approaches to developmental delays, where Dr. Stephen Porges identified that the autonomic system actually has 3 different levels. When the child feels safe, he's at the top of the ladder, he's interested in learning of skills can take place quicker. When the autonomic nervous system is activated, the child is very much in a mobilized state. And then, of course, when the system is totally overwhelmed, the child moves into a survival state. We can also really refer to that as the brain needs to be happy. And it's a subconscious, unconscious process that you cannot reason with. And as long as that is part of your approach to early detection and intervention, you will move much quicker. Crying is also part of that, where studies recently are indicating that should the child be extremely upset, in other words, the autonomic nervous system is activated, that you should actually stop your therapy or your with the child and then continue when the child is engaged and interested, because that is also the motivation, the interest, the making sense of what we're busy with is what makes the connections in your neuroplasticity happen. Outcome measures is something that I'm sure we are all familiar with, which is basically just referring to how can we know that we actually improved our intervention, apart from just saying there's a improvement or a subjective judgment thereof. What is nice about outcome measures, and remember an outcome measure, take a look over time. You can also plan your intervention according to the triage of your outcome measures. Okay, so where do we start when we actually look at the developmental delays and the early detection? So we all agree that wait and see is the outdated approach. The earlier, the better. And if I take you back to the pyramid of learning, you know, if you really want to go into which is do your assessment to understand where in this complex structure is actually the gap, we will never end with that conversation, because even with preterm births, with term births, and we know right through childhood, there are different standardized assessments, there are different developmental scales, developmental norms that can actually address each and every of these little aspects of the developmental networking that takes place in the pyramid of learning. So I don't really want to go into detail of what's the best tool, what to use when, because that's where our clinical reasoning is coming in very handy to make those decisions and apply them to each and every individual case we work with. The one question we should ask, however, do we work bottom up only in the pyramid, or do we work top down as well? And in the middle, we catch the family and the child, who we can actually confuse if we have not a clear vision of what we are actually busy with. So the question is, how purist should we be in our approaches? And my counter question to that is also, how pure is life? We know that life is a very dynamic process. And what the evidence is saying lately is that a combination of therapy disciplines and a combination of therapy approaches is truly where we get the best results from. Teamwork is therefore also extremely important. As we all know and understand that when we look at the pyramid of learning, I don't say nobody is an expert on all and every level of that pyramid. However, we are very aware of the fact that different disciplines specializes in different areas of development, and pulling that all in together to give the support it needs to ultimately give the child the optimal level of functional performance is really what we strive towards. So teamwork, therefore, is also a matter of inclusion, but also pacing. Who should come into consideration at what stage? And again, if you work in an interdisciplinary team where multiple disciplines are engaged, we can really make the best decision for the child and the family. So I thought to end this presentation looking at a few scenarios when it comes to the pyramid of learning, and I have included all of them here, but we're going to go through them one by one. If we talk about attention and focus, we can see our pyramid is fairly to full capacity involved in the development or the establishment of attention and focus. We can see there's definitely a combination of a bottom-up and a top-down approach. And yes, there's definite focus on the training of higher functioning skills while we are still focusing on the foundational areas of the sensory system, the neuro reflexes, the motor system. When we look at emotional behavioral regulation, again, here we see the bottom up and the top down approaches working together. There's maybe a little bit more of a heavy focus on the sensory parts, but again, also we do not let go of the higher functioning skills. When it comes to dyslexia, there's more emphasis on of maybe the reflexes. Dr. Nageena will go into that. But it's a more focused, more specific intervention we are looking at. Dyspraxia, again, very similar. And here we can see there's a heavy emphasis on the motors aspect. So maybe physiotherapy, occupational therapy will be more involved in these. Handwriting, very focused skill that we are working with. Socialization, here we see a very heavy emphasis on bottom up as well as top down structures. And also with learning difficulties, which is more than just a dyslexia. It's more than just a dyspraxia. So again, bottom up and maybe less top down, but a heavy combination of skills required to assist the child to optimally develop. Speech development, again, much more focused, less of a bottom involvement and more of a mid-range of skill involvement. So to make a final word or two, when we work with pediatrics, clinicians work in a very complex system. The planning and the execution of the system is therefore also complex. The individual skill of the practitioner working within this service is therefore quite important. I really like to end with this quote saying that while we try to teach our children all about life, our children teach us what life is about. And I think it's very true for us as clinicians as well. Thank you kindly. There is a list of all the references. I am going to stop share here. Pardon me, I just need to get into the webinar mode. We will look at a few questions at the end of the presentation. I hope that gave you some insight into how we as therapists look at developmental delays and the early detection thereof. But I would now like to hand over to Dr. Nageena, who is our expert chiropractor in the field of reflexes. Good evening, Dr. Nageena, and I am handing over to you. I'm not sure if I pronounce your name correctly, but welcome and please.
Thank you very much, Judi. It was an absolutely insightful presentation you gave us here, and it really follows on beautifully to what we're going to talk about. So thank you so much, and I'll see if this is coming in through here.
Perfect.
Okay, hello. Good evening. I'm Dr. Nageena, and I'm going to be talking to you a little bit about the role of primitive reflexes on that kind of learning that you saw with Judi there. And here's a little version of my own that I have. And what I do is I start actually even before the primitive reflexes with prenatal conditions and mother's health more so. But it all boils down to what I'm going to be working around is the primitive reflex section here, for you to also understand how all the other elements of learning can be affected and all the other aspects of development can be affected. So we're going to be talking in terms of also a left-right approach, a hemispheric model, briefly touch on that. But in order to understand what a brain imbalance is, or why are they more so prevalent these days, and why are we seeing so much more developmental delays, it's really important to address the stages of brain development and see how the brain actually develops and how it grows, and where possible, where we can identify the errors in its development or any glitches that may be occurring across the blueprint that it's designed to be developed at, and what milestones, if possible, are being interrupted and how so they are being interrupted, and what we as practitioners can do to address it and to correct it possibly. So it all starts with the stages of brain development, and we all know, don't worry, I'm not going to go into neuroanatomical information so much, so it's going to be quite basic, so we all understand it very well. The main stages of brain development, as you know, are growth, segregation and localization, integration, both vertical then horizontal, then we get a synchronization, lateralization into left and right hemispheres, then we get pruning and refinement. Now, in order for the brain to start growing, it needs to go through a stimulation process. As we know, the brain cannot be fully developed at birth because the birth canal of the mother is too small for birthing a fully developed brain. So the brain must continue to grow outside of the uterus once born. And it knows this only simply because in the uterus, while in the womb of the mother, it's in essence in a sensory deprivation chamber, limited access to light, limited access to smell, limited access to touch, temperature, gravity. So it has senses of this, but when the child is birthed and is out into the world, it is stimulated, inundated with sensory stimulation. And that's lots of light, gravity, temperature, touch, smell, sounds, and it's just completely inundated with the sensory stimulation. And this causes the brain to start to grow. Because at birth, the brain, although it has mostly all of the cells it will ever need throughout life, it has only 25% of the birth weight of the brain, and mostly it is at the brainstem level here. So in order for it to now develop, it will be stimulated with all of these senses and certain neurons. Like, so this is also the genes that are stimulated are the experience dependent genes, and they respond to certain stimulus. So some neurons will only specifically respond to light, some to touch, some to gravity, some to sound, some to movement, and so forth. And what this does is this creates the brain to start to grow upwards, and it starts to grow upwards, and the cells start to segregate and connect, so they become more localized. So certain cells that are responding to light will all start to aggregate and start to develop and move up into the brainstem and start to become and form part of the vision section, which is the occipital lobe. Then we'll get similarly with touch, it will move into the parietal lobe, and with movement, it will drive into the frontal lobe, and with sound and hearing, it will move into the temporal lobes. Now, it's not only enough, so the segregation and localization of these cells are developing into the growing brain. It now needs to integrate these senses, so they go into the process of integration. Now, this initially occurs in a bottom-up approach, which is what Judi touched on as well. So the bottom-up approach is that the brain is going to continue to develop up the brainstem as long tracts, and then they will need to integrate first vertically upwards and then horizontally, so they cross over onto the opposite sides and start to have cross hemisphere development. And this is going to continue as they move on. And as this is continuing, the brain starts to synchronize. So now we need to have connections from the left and right hemispheres occurring through a process of synchronization, because even though we will get long tracks going across from one side to the other, not just physical connections will be occurring, but we will get more timed mechanisms occurring. So they fire simultaneously at the same time through the process of synchronization. Now, this doesn't mean they are what we call functionally connected. They don't have necessarily physical connection. So they have a timing mechanism in the brain, which is frozen in time and space, that allows them to sync the firing rates of these neurons. So this is really crucial when we look at what's happening in the child with developmental delays, because if this process hasn't occurred appropriately at the right time, we will have left and right inability to coordinate, hand-eye coordination issues, foot-eye coordination issues, just generally disconnected from body and senses. We move on to then, after we synchronize the timing mechanisms occurring in the brain, we will move on to lateralization. So what's happening now is that the brain is becoming, although initially it's going to become very similarly designed, but as the child grows and continues to develop, the brain becomes more asymmetric. And this is actually a evolutionary advantage for primates, because it gives us two brains in one. Now, each side of the brain does both things. So like occipital lobe will have vision on both sides, but both do specific things slightly differently. The same is for the frontal lobe. So if we have greater vision, so the right brain will be more open to peripheral vision and bigger picture skills, where the left brain in the same area will be more on fine, more detailed, analyzed detail of objects and so forth. And this will enable the two sides of the brain to be doing different activities, but in a bit more of a skilled manner. So this is giving us an advantage evolutionarily, that we have two brains in one through the process of lateralization. After this, we will have what we call pruning and refinement. And this will enable us to remove networks that are not being utilized or developed, and the brain just starts to remove them. And this continues through life until about the age of 50, where I understand the brain starts to shrink, although the brain is forever neuroplastic, which means with the adequate and appropriate stimulation, we can always cause it to develop further. Now, again, like we're going to look at the way that the brain develops. It's in stages, similar to a cake. So it starts from the bottom up, and then the top-down approach takes over the brainstem. So in the purposes of this presentation, there's so much to cover, but I want to give you a base of understanding that this is how the brain is developing. It's moving from a bottom-up approach, and then the top-down control needs to occur in order for the autonomic nervous system to be working appropriately, which is sitting around the brainstem, which is where the brain development starts. So this is the pyramid of learning, which we've all looked at, and we're looking right at the bottom, just where the central nervous system is, where the neuroreflexes exist. And what these are what you've all aware of, the reflexes the child is born with. And these are automated movements that occur in order for the child to allow the brain to grow. So we know that the brain is 25% at birth in weight, and this triples in size in the first year of life. And this is primarily due to these automated movements which are coming from the brainstem, which allows the child to start to develop. And these are mostly for survival in the first 6 months of life, and they should become inhibited as the brain continues to integrate, as we know through brain development. Now, what's happening in the child where these don't occur, because the child should have a blueprinted amount of where these reflexes occur and when they should integrate and when they should go away, and then postural reflexes emerge and so forth. Now, if these remain, this causes developmental delays in children. Now, these can come up depending on how many reflexes are not integrated or inhibited by the frontal lobes. These will cause a whole host of different symptoms that we see in children. And we have multiple labels that we give and assign to children. I'm not a fan of labels from a personal experience, however, but I do believe that if we understand the nature of the developmental process of the child, we may be able to identify what type of symptoms they may present with later. But if we can address them early on, in early infancy, we should be able to help them limit or even prevent them from continuing. But we need to also address different aspects of development in terms of metabolic, genetic, nutritional, and all those other aspects that I'm looking at. Just from a reflex perspective, we can address these extremely well, and to be able to help these children very early on through our care and all through clinical professionals that are working with children. And why do they persist? There's a number of reasons why they can persist. Preterm babies, neurological disorders can cause these traumatic brain injuries, falls, genetic conditions, environmental factors, poor nutrition, metabolic disorders, infections, and so it's extremely important to address these, especially in prenatal care for mum, gestationally. We must address any type of illness and try and correct these prior to the delivery, which can also allow the children to develop further illnesses, because their nervous system is immature and they need a lot more care and nurturing. Certain other issues can cause developmental delays and allow these primitive reflexes to remain. Our sensory processing disorders, any chronic stress in the parent, or exposure to any adverse childhood experiences can also contribute to delays or retention of these reflexes. So we need to make sure that the child has a good nurtured environment, that they are loved and cared for, and have the adequate nutrition and care that they need to have a optimal development. And sometimes the children don't have the neurological maturation occurring, and we mentioned brain injuries and infections also, like hypoxia during birth processes, can also cause reflex retention, and nutritional deficiencies that we've mentioned before. And so what these do is the retention of primitive reflexes have been well versed and well documented now. There's a lot of research that is out there that shows that the persistence of primitive reflexes does cause or is comorbid with developmental delays, particularly ADHD, ASDs, dyslexias, dyscalculias, that these persistent or reflexes in different combinations can cause different symptoms in children that we are seeing daily in clinical practice at home. And what we need to do is find solutions to help them in a simplistic way with simple movements that haven't been stimulated adequately. We need to go back and stimulate them. And the purposes of this is to highlight which reflexes that can be the most powerful to cause these changes that we want to see. There's, roughly around 30 primitive reflexes. Some literature says more, but purposes of teaching and to explain, I think if we look at the main larger reflexes, if you like, which have most of the neural integration processing happening, it will be brilliant to start here. Because as we know, neurobehavioral disorders and neurodevelopmental delays are quite taxing on the families and on the population. 1 in 10 children in these are the US state stats are diagnosed with ADHD and are medicated mostly. And there's a huge components with statistics with developmental delays across the globe. So it's not just in the States or in the we don't have actually stats for the UAE. I haven't been able to locate any, but we've got statistics around the world, and we see more and more children are showing a lot of learning disabilities, learning delays, difficulties in behavior, difficulties in learning, difficulties in literacy, numeracy, and it's across the board. So it's in the US, it's in the UK. Children, 44% of British 11-year-olds do not pass the standard reading and writing and maths tests. And these are really concerning statistics that we need to really act fast on to ensure that our next generations are literate, they are able to access learning in a nurturing environment, in a mainstream environment, and that we are able to get them to develop to the best versions of who they're supposed to be with simple things that we're going to teach you, like Judi mentioned, the therapies that they do and the therapies that we can do, and particularly even chiropractic on its own is so crucial in helping these children. But when we can focus our adjustments more specifically to the weakness of the hemispheric model that we're going to talk a little bit about, it's going to be much more powerful for these children, and more children need our care because there's so much more prevalence of neurodevelopmental delays and neurobehavioral disorders. Unfortunately, I couldn't find any in the UAE as yet, but I'm sure, as you all know, that we are seeing more and more prevalence of neurodevelopmental delays and neurobehavioral disorders. And we're seeing the production of medicine is increasing 2,000%. And what's concerning more so about this, medicine has its place, by absolutely it does, but the prevalence of giving medication and to look at the results of said medication to the children is extortionate. It's costing a lot to the governments, a lot to the families, a lot to the child itself. And when we look at the effects of medication in terms of children with ASD and ADHD, we look at the stimulant medication that was mostly used, and this is the MTA study done at 8 years, done by the medical profession, to show that the medication sadly has no long-term effect, and that's no long-term benefit or long-term effect, which means when you think about it and sit with that for a moment, it means that children that are on this medication will need to remain on this medication. And that's really quite concerning, that if we're starting our children at 4, 5, 6 years old on some of these medications, that they will need to remain on some form of medication to help them to be able to access learning in school. And we really want to be able to address these issues for more of a core, like where the cause is coming from. Like, as chiropractors, I know we absolutely love to find the cause of the problem and work on it, not just work on the symptoms. And again, similarly, this is what drove me to this, was my own personal experience with my own son when he was developmentally delayed, significantly so. And I was told that, he'll probably remain nonverbal for the rest of his life and need 24-hour care. I made it my life's mission to find ways to help him. So let's talk about primitive reflexes and why they are so important. Well, this is where it all starts, right? It starts with the neurodevelopmental aspect of these reflexes. Once we can get these to integrate on the right time, we can get the child to move along that blueprint that the brain is designed to follow, and development will occur as it's designed to. We don't teach the child to roll over. We don't teach the child to suck or swallow. We don't teach the child to be birthed. We don't teach the child to stand up, cruise, or walk or crawl. These are all inherently, innately in the child's blueprinted DNA. It's meant to do it to an order. And so what we need to do is know that order, and then to be able to ensure that the child is following that order. At birth, pediatricians always check the reflexes are there, because if they're absent, there's a neurological problem right there. But no one ever checks. It's an assumption that they disappear after a year. But this is not the case. And more when we're assessing these, we see that they are still present and that we need to address these. And we need to address them rapidly and quickly in order for them to integrate faster. The longer they are there, the longer that we're going to have delays and lack of connectivity between the two sides of the brain. And then we're going to have a whole host of symptoms and lots of different labels depending on which reflexes are present, in what combination they're present, and what part of the pyramid of learning is being affected. So what we need to do is address them, correct them, get the child to do the movements, help the child to do the movements if they can't do them initially themselves. And then we just continue working through all of the reflexes. And then we also work with the hemispheric model, depending on which side of the brain needs more attention. We work on that. Now, this is important because when the brain is developing from birth, it is not developing in parallel, it's developing in series, which means in the first 2 to 3 years of life, the right side of the brain, the right hemisphere, is more electrically active than the left side. And then from the age of 3 to 6, the left side becomes more active, electrically active by 20 to 30%. And what this does is it's switching through side to side throughout their life up until adulthood. And this switching of sides, and if there's a glitch even here, what you'll see is the child may have the right side staying online too long, which makes them super anxious, makes them very intuitive, but they will have the dyslexia, dyscalculia, other type of reading difficulties, visual processing difficulties, auditory processing difficulties, but they will be very in tune with social empathy, understanding. But these are children that later develop depression and stress and anxiety. So when we address these issues early on, we can, in essence, help all of the other symptoms that are associated with a brain imbalance. And it all boils down to, when I looked at it from, researching this for 12 years for my own son, I understood that the brain development aspect is so crucial in order to get the best care for the child and for the therapies to be so effective. We need to know that the order that they are the most effective in. So it's really important to understand the impact of the retained primitive reflexes, because it's a missing link. It seems such a simple thing, but it's so important to be able to address these. And the beauty is it's so simple. It's simple to be able to address these, to assess these, and to integrate these. Sometimes it takes a lot longer if they've been there for longer, but we know that when we do start to stimulate these, I've seen miracles in my own clinical practice, and I want to have that for all of you so that you can share, because there's not enough of us doing this work to help the children that need us, and we need to be of more service to the children that need us and the families that need our support in being able to provide this care. So, if some of the retention of these reflexes, you may recognize some of the symptoms here. We need to be able to address these in order to have the child be the best version of who they are meant to be. So just a little recap of our reflexes. This is the Moreau reflex. It's just the most cutest little thing. Let's have a little look here. I'm not sure if you can hear it.
Reflection, comfortable, unsuspecting as soon as it's coming, and then we will drop the baby for a few inches. It goes out into extension and flexion of the elbow, and then gradually comes back in. And oftentimes the hand is in a seat position with the thumb and the index finger. Do that one more time. Just watch the movements of the hands. goes out, and oftentimes there'll be a little bit of a fry there. Okay.
That's the Moro reflex. If left unintegrated, you're going to have a child that's going to have, we're going to be really easily startled, high cortisol levels, adrenal fatigue as they're older. We're going to have children that are unable to regulate their nervous system. They're going to be in a state of alarm all the time. They can't sit still, and they're very, very active. And this reflex should be gone by the age of 2 to 4 months. So we should allow the child to elicit the response and for it to integrate. And the simple exercise is if the child is like, let's say 4 or 5 months, you just continue simulating it until it integrates. But now if the child is a 2 to 3 year old, you will need to simulate it perhaps on a ball. So you can rock them back and forth on a gym ball to simulate that response. If they're a bit older, you may need to simulate the actual starfish type of exercise. And all of these exercises are available on my website, bit of self-promotion, drnageena.com, but they're all available for download. You can access them to learn how to do these exercises. They're also on my Instagram page for all of you to just access and teach the children how to integrate these. The tonic labyrinthine reflex also is helpful. It's more to do with postural control, both flexion and extension. If this does not integrate at time, you will see these children as forward flexed postured, children that are constantly slouched. They just cannot sit up. They cannot sit still. And this allows for poor neck control, poor central truncal control. This doesn't allow the child to have good muscle tone. Central vestibular, central cerebellar work is not functioning as it should, and they often are clumsy and is often labeled dyspraxic. And so what we want to do is ensure that we do some TLR, reflex integration, and simple stuff like if the child is this age, you will encourage this movement. So the rehab is particularly the way you would assess it. And even as they are older, when we're assessing the reflexes in a child who's over 4, 5, 6 years old, you would stimulate the reflex to assess it, and then you would integrate it by repeating that assessment. So that helps integrate it. And also for the palmar response, this is also for gripping and allowing the child the grasp response. This is very directly related to, I'm very cautious of time at the moment, so I don't want to overrun, but the palmar response is directly related to the Babkin response and the rooting response and the suck response. So hand-mouth coordination is crucial for this. If this is not developed, or like it doesn't develop properly and then doesn't integrate, we have nail biting, we have poor fine motor control, we have poor grip, poor grasp, poor feeding ability, self-feeding issues. We don't develop the exploration of food adequately with Babkin. And then if the mouth reflex is not integrated either, we will have severe sensitivity to textures. We will get the extremely picky eaters. We will not establish the muscles of mastication or the facial muscles of expression because the muscles that are required for chewing are not developing because the suck reflex is still present. So these children will often have a lot of oral sensitivity, textural issues, and will be very picky eaters. So we need to work on the palmar, the Babkin, and the rooting and suck together in order to ensure integration of this. And all of these exercises are available freely on the website or Instagram. But if you touch base with me, I can provide you some information on those. So the next is the spinal galant reflex, another reflex for birthing and survival. So it allows the child to wriggle out of mummy's tummy. If this is retained, you will have children with prolonged bedwetting. They will have what we call ants in their pants. They cannot sit still. They need to be moving constantly, side to side. They have extreme sensitivity to clothing touching them. What you do is stroke the back.
You can see that there is a positive along and having the baby relax. The other.
So the spinal gland, so you'll see the body move, and these are the children that are severely ticklish. Being severely ticklish is not normal. Being ticklish it is, but when we're moving so much like that this indicates the reflex is still present. If one side of this reflex is present, you may get a scoliosis as well. So this is really important for children with what appears to be developing scoliosis, you must check for the spinal galant reflex and start to integrate it so that the spine can develop as it's supposed to. But that's also related to the vestibular spinal and vestibular ocular reflexes, which is a completely different seminar entirely. But what we can start off with is the spinal galant reflex, integrate this to prevent more tonal discrepancies between side to side, and also this will help bladder function, bladder control in the developing child. And this symmetrical tonic neck reflex, this is the precursor, not truly a primitive reflex, but the postural reflex. So the child must go through the crawling phase. Now, this I want to really just hone in on, because recently the CDC has dropped the crawling as part of the recommended milestones. And I think that's absolutely astonishing. And I'm distraught about that, because it is the most important reflex for left and right integration of the brain hemispheres. It's crucial for brain development. So if a child doesn't crawl, it's important that you teach it to crawl by putting it into the position and rocking the child so that it goes into the rocking back and forth, because this reflex is directly related to convergence and accommodation as well. So this is really important, that if the child is and postural control. So it has so many elements of learning associated with this particular reflex. So it's really imperative that we ensure the child is developing all the reflexes on time, and they are integrating on time. So if you hear that the child, it doesn't matter if they don't crawl, it's important that you correct that and say that it's absolutely imperative that they crawl for the best optimal functioning brain that we want for all our children. The same goes for the asymmetrical tonic neck reflex. This is the reflex which causes a Fencer response in the child. And this is also to do with the eye tracking, so saccadic eye movements, pursuit eye movements. So this will help develop the midbrain as well in the developing child. And it's really important that we check this and integrate these particularly. I'm just cautious of the time. And I'm thanking you all for your patience with me here. There's so much to get through. And there's so many other reflexes. I just put in some extra ones in there for you to see. And so basically, in a nutshell, we're born with numerous primitive reflexes to keep us alive. All should be gone by the age of 12. Any of these will cause an impediment in development of higher brain function and top-down control. The simple tests that can be done and integration exercises can help significantly. Now, what I do in clinical practice is add a hemispheric perspective to this, which means I identify which side of the brain hasn't developed more so, and then we stimulate that through the senses that it requires to be stimulated through, because you know the left and right brain have separate functions. They do the same thing, but separately. So like the left side of the brain responds better to colors like red, yellow, and orange, whereas the right brain responds to better colors like blue, purple, and violet. So these colors affect the left and right hemispheres differently. Low tones are on the right hemisphere, and negative tones are addressed more on the right hemisphere. More positive, happy tones are on the left hemisphere. So these components are what we assess for in a child when we are checking them clinically, and then we can address and make a unique program for each child that comes in depending on what is happening. So that's what we do in clinical practice. But simple exercises are extremely helpful to help the child develop in the best possible way, and it's never too late. So it doesn't matter how old the child is, because the brain is neuroplastic. We can help at any time. It just means it may take a bit longer, it may take a lot more effort, and we need to look at all other components of health as well, not just this part. This is just one piece of the puzzle. We need to look at nutrition, diet, nurturing, environment, stimulation, screen time, and all other aspects of development as well. And it's a bottom up and a top down approach. So absolutely, we need to work from the neurodevelopmental aspect and move it upwards and then back down. So the hemispheric approach is basically we work on the crossing the hemispheres and ensuring that we get integration of not only the primitive reflexes, but localize the areas of the brain that are not developing well. So in terms of like if the child has issues with speech production, we're going to focus more on Broca's area. If they have comprehension issues, we look at more Wernicke's area. If they have inability emotional regulation. We'll look at more the limbic system and the amygdala, and how to stimulate these areas, and how we can use smell and senses to help regulate these in the children, along with all of the neurological exercises that we can do. But what we need to ensure is we start with the developmental aspect of finding where the brain hasn't developed fully, and to start from there and to develop the child from that perspective, with adjustments. So every child with any type of neurobehavioral disorder or neurodevelopmental delay must see a chiropractor, not just a chiropractor or a cranial osteopath. These are amazing, but I'm going to be a bit biased because I'm a chiropractor and I love chiropractic. And I saw 6 chiropractors for my own son to help him. But the adjustment, Heidi Harvick's research shows that an adjustment performed in a specific manner to the child causes neural integration in the brain, and it has been identified. So it's an amazing novel stimulus to the brain, very powerful to get the child to develop and regulate the nervous system very, very fast. So we start with the basics. You adjust the child, and this is like we get more and more proprioceptive input from adjusting. You know, if we do one-sided adjustments, particularly, we can get more of a impact on the child depending on which side of the hemisphere needs more work. So we can do a separate seminar for chiropractors and osteopaths, if you like, to talk about that in a bit more detail. But right now, you know, take your children to chiropractors and osteopaths and get them adjusted, so that they may have more nervous system regulation, and that they may respond better to more therapy with OT, speech, ABA, as the child's healthcare plan demands. So I'm very aware that my time is up. So we'll have to do part 2. So thank you so much, and we'll continue on another day. So thank you very much, everyone, and I will pass you over to Dr. Charles.
Thank you so much, Dr. Nageena. This was truly very insightful and interesting, especially coming from a mother. I have a lot of respect for that. It brings a whole different emphasis to what you are talking about. So thank you so much. And definitely, I think we should look at the next webinar in future. Thank you, Charl. Charl is part of our team here at Hope. We are very privileged to have him as our in-house orthotist, working with physiotherapy, OT, and speech language, mostly here in Hope. So, Charl, we look forward to your contribution to specifically infant head-shaped deformities. I hand over to you.
Hi, good evening, everybody. So yes, I'm an orthotist, prosthetist. I own Orthomina, and I have the privilege of working with Hope very closely. We've introduced a cranial clinic for them, a cranial screen and intervene clinic, as well as we do scoliosis programs. And what I must say is pretty amazing scoliosis bracing. I'll get the show on the road. I've got big shoes to fill. There was 2 fantastic presentations, and I think they totally coincide with the information that I want to provide you. So I'm just going to share this. And please let me know if the slides play right. I'm running in the blind here. So today I'm going to talk to you about infant head shape issues. I want to say that all the information that I will provide today is evidence-based. I have the literature, it's peer-reviewed, it's sound advice, and the subject matter that I'll be focusing on isn't a gray zone in healthcare. It's proven, and it's white and black. The evidence is on paper. We are going to be talking about head shape issues that we see in infants. So we're going to be talking about predominantly positional head shape issues. This is plagiocephaly, brachiocephaly, and scaphocephaly. Now, I'll start off with one of the biggest misconceptions that there is, that these head shape issues just resolve on their own. You know, this is a fallacy. This is not true. It results in a lot of tears, a lot of anguish, and it results in parents not getting the timely advice and the ability to make an informed decision how to treat their child's condition. Now, what that treatment is depends on the child's age. But as soon as the parent receives a bit of information that a head shape issue will just spontaneously resolve, they abide by that advice and there's no intervention. That intervention could be something as specific as education around repositioning strategies, or it could be something more complex. But as soon as that advice that it's benign and it can resolve its own is given, that timely intervention, unfortunately, has fallen out of the window. This is a WhatsApp message we get. We get these messages all the time. It's concerned mothers and fathers contacting us about their children's head shape. Often these babies are 12 months old, they're 14 months old, they're 18 months old. And all the evidence shows us that there is nothing we can do about this head shape. Now, you'll ask yourself, what is these head shapes that we see? And I'll show you here. This is a scan of actually one of those head shapes. And this is the actual scan of the baby's head. You'll see the top part of the screen is the back of the head, and the front of the screen is the front of the face. So roughly in the middle, we have huge occipital displacement. I'm going to play the rest of the scan of the baby. And so we have lateral displacement of the occipital bone. We have displacement of the frontal vault. And we've got displacement of the cranial features in the front of the face. When we look at the scans of the infant, we know what plagiocephaly CT scans look like. And again, for some reason, people have always downplayed this, that it's an acceptable asymmetry. But when you delve deeper into the actual scan, and when you look at the prints that we do of these CT scans, you'll see that there's a global involvement of these asymmetry. It's not just a presentation on the back of the head. We have the nasal aperture affected. We've got a jaw alignment. We've got both the maxilla and the mandible involvement. We have the zacchosomatic bones. You'll see that even the facets and the processes are involved, not to mention the actual foramen, specifically the magnum. And we're going to be looking at that a bit later as well. Now, nobody's got a symmetric head. The last thing that we're trying to advocate is that everybody would be symmetric. We've seen the Photoshop images where you take a left and a right and you give somebody a perfectly symmetric head, and you lose depth, you lose perspective, you lose perception of the actual face. So the asymmetry gives us these telltale perspectives that give us our look. However, as soon as we move past what is acceptable, which is roughly a 3.54% perspective, then we start seeing interesting things happen. Now, this just happens to be a set of twins. This is the sister. And from all aspects, she's a beautiful young girl. However, she's got a brachiocephaly presentation, which is an asymmetric brachiocephaly. She's got a head that's wider than it's actually long. So she has a cephalic index of 100. And when you put the two features together, maybe you could say it's just a cosmetic feature. However, this mother never received the opportunity to intervene when she was continuously requesting if this was something could be done about, to be informed that it's something that corrects spontaneously. We know the cranial anatomy very well. I'm not going to delve into too much detail in this. We know we have the sutures. We know different practices, disciplines have different ways of treating it. I think there's a lot more commonality across disciplines, and there's a divide. We know we have the sutures which include the metopic, the coronal, the sagittal, the lumboid, and the squamosal. Now, we know we have these fontanelles on the anterior, the posterior, and the mastoid. But when you look at this, none of these have epiphyseal growth. When you look at the jaw, that's the only place that actually has epiphyseal growth that can steer development. All these other structures rely on intracranial pressure, as the previous presentation very specifically mentioned. The vast cranial growth we have in the first year and two. We have this dynamic, huge increase in cranial matter. The brain's growing so rapidly. that through evolution, we weren't developed with epiphyseal plate growth. So we have these sutures that allow rapid formation. It's also important in the birthing process of an infant, but predominantly today we're going to be talking about positional head shape issues. We know if there's early fusion in these areas, we have a craniosynostosis, and that's a subject of another day's discussion. However, you'll see that the same intervention and early screening strategies play a huge role in treating early fusions. As soon as you have a craniosynostosis and there's an early intervention, the procedure goes from a total degloving and a full craniotomy to a very minor endoscopic procedure. Hence, driving home that early intervention plays a role not only in positional head shapes, but also in cranial synostosis. We know that during birth, the head has to rotate. We know that the birth canal is relatively small. We need these little tectonic plates to move around each other so that the birthing process is easier. And again, as identified, we have this huge rapid growth trajectory in the first 2 years of life. So at age 24, the bones have mostly interlock and fused. These sutures start fusing. So the brain volume doubles by 6 months, and then it doubles again by 2 years. And after that, there's no external force that can reshape these bones. And if we envisage that as the internal shape that's creating the shaping and the molding, you can understand that if we have an asymmetry or if we have a deformation, intervention will be required, and that will require something from an external nature. When we talk about the growth of the head, we all know that there's 2 separate areas that are at play. We have the neurocranium, so we have the skull that houses the brain. This is that area that grows rapidly, and we see that rapid growth in a child. And we often look at an infant and all we see is head. And when we look at a 3-year-old, all we see is head, is this huge neurocranium. Then we have the visceral cranium, which is considerably slower in development. In fact, up to the age of 18, 20, our visceral cranium grows. And very often, this growth of the visceral cranium is the debate that I hear, that a cranial asymmetry will correct itself. Now, this is unfortunately not true, because the visceral cranium has a scaffolding that's based on the shape and the asymmetry of the neurocranium. In the same sense, I often tell parents that if they have a mild asymmetry, not to worry, because the overall percentage of head is considerably bigger in reference to the body size. But as I said, the actual shape of the neurocranium will dictate the symmetry of the visceral cranium, and that additional subtle changes that the visceral cranium goes through isn't sufficient to have a reverse effect on the neurocranium. We know there's different types of positional head shapes that we see. We have a plagiocephaly. Now, plagiocephaly is predominantly identified by asymmetry. Very often the asymmetry that's present on the posterior side of the head with the occipital displacement is also present on the front of the face. And that's one of the identifying traits from a craniosynostosis. It's almost like a box that folds in, and the posterior asymmetry manifests itself in the same position on the front of the face. We often get cranial vault involvement in the front, displacement of the jaw, the eye orbits, and then also displacement of the ear. Now we get brachiocephaly, which is a posterior flattening over the full surface of the back of the head, where we have the occipital bone actually compressed in, where we have the parietal bones opening up. The brain needs space to grow, and if it hasn't got the space in the occipital area, it finds space in the parietal areas, and we get the wide sides of the head to have this brachiocephalic shape, as well as a very steep lateral cranial vault that's predominantly high in the posterior side. Then we get a mixture of the 2 presentations. We have an asymmetric brachiocephaly, which is different from a regular brachycephaly. That's a combination of an asymmetry and a brachycephaly. So that is where we have a CI index that's greater than 3.5, and we have a CI index that's greater than 80. And then the one positional head deformity that we see often is scaphocephaly. Luckily, we don't see this as often due to improved NICO treatment guidelines. So we don't get these flat, elongated heads anymore because they proved quite hard to treat. Now, why are they so susceptible to deformity? Why potentially weren't these head shape issues such a big problem? We know that there's extrinsic and intrinsic reasons. We know that there's a lot more IVF. We have a lot more intrinsic or restrictions due to multiple births. We have twins. We know that extrinsic, we have practices like swaddling. We have babies that are maybe not getting mobilized as often. And predominantly, one of the biggest reasons is the back to sleep program that was introduced to reduce the incidence of SIDS. Now, I always say one of the worst things for business is having a live-in-home grandmother. Grandmothers know what is the safe zone to position a baby. So where the mother would always have the baby sleeping on the back, we see specifically more experienced parents able to position them more on their side and actually get the gains of repositioning. Of course, the gold standard is to put a baby back to sleep on its back. Now, again, we have multiple births. We have breech positions. We see an incidence in forceps and vacuum-assisted deliveries. We have higher rates of premature birth survival. And all these in combination with this back to sleep program is the reason this new phenomenon has showed itself present. Of course, there's a huge role of torticollis. That could be a presentation on its own. We know that the standard choroidal mastoid can either be weak or it can be tight. It needs a proper assessment, but we know there's a correlation between an asymmetric head and torticollis. We know the torticollis also presents itself on the front of the face. But these two conditions are totally interrelated. Now, what is the diagnosis? The diagnosis, firstly, is to identify the severity. Just having a look at the head and deciding it's asymmetric or not is not sufficient. The Pediatric Association of America has very, very stringent guidelines around it. And a tape measure that does a circumference measure is not sufficient. To quantify the severity, it allows you to frame that severity in a window, and then there's indexes around what the treatment should be for the age of the patient. What is the calendar age of the patient? Then interventions can be given that are evidence-based. We know again that head circumference is not the primary assessment. Of course, it's an important indicator. Most often the absolute head circumference may be normal, despite the head being very asymmetric. You can just think that a circumference measurement irrelevant of a head shape is not going to give you a head shape percentage deformity. Now, there's anthropometric landmarks that can be measured. There's specific special tape measures that can be used, or alternatively, the spread calipers. They're cheap, then cost effective, and it's something that every pediatric healthcare practitioner needs to have if they are treating positional head shapes. And when a deformity is present, we have different landmarks that need to be measured. Predominantly, it's the head width, the head length, and the width and the length, and then the cross segments. It allows you to reference guidelines. The two guidelines is the cephalic index. Now, the cephalic index is a ratio, a proportional ratio of the width versus the length. This is used for scaphocephaly and it's used for brachycephaly. If it's a brachycephalic baby, the more the index goes to 100, the more square the head is, and the more the presentation presents itself. You can think a head that is, for instance, 140 by 140 is going to be a severe brachycephaly. And on the opposite side of the equation, a head that's significantly narrow in ratio to its length is going to have a very low CI index. So then we're looking at 78. And there's guidelines according to the age of the baby. These are freely available. And a baby that's outside this mean age needs intervention. Now, before 4 months of age, as early as 1 and 2, of course, it's going to be a more conservative approach. It's dedicated repositioning. It's a treatment and identifying a torticollis. And it's early intervention strategies according to your discipline and your speciality. When we look at that, this is the guidelines. We have posters available in all of this. We have beautiful posters around pediatric management. If anybody's interested, please just drop us a message at the end of this presentation for a PDF so you can see these that display the guidelines. And if we're talking of an asymmetry, we're looking at a cross-segment ratio that should roughly be zero. However, not everybody is perfectly symmetric. We know that normal is 3 millimeter, but as soon as we move past 10 millimeters, it means that we have significant cranial involvement that involves more than just the shape of the head. We've got other structures that are involved. And those are the CI or the CVAI, the cranial vault asymmetry index, is a percentage of asymmetry, which again can be done with the spread caliper. Can it be prevented? Absolutely. If we do our work and if there's early intervention and if parents are properly educated pre-birth in these classes to be careful for these positional head shapes, then there's a window of opportunity where the development of the child is of such a nature that repositioning can be effective. After 4 months of age, that child will never be in one position long enough for external force to be subjected to the cranium to create a correction. So 4 months is our window. So treatment starts at 1 month, at 2 months. And countless times, parents raise the alarm at this age to be downplayed, to worry that it'll correct on its own. Of course, we need to early and identify diagnosis. It needs to be quantified so it can be tracked. Acquiring accurate anthropometric data, adequate education around repositioning can't be done in 5 minutes. Parents need a detailed explanation what tummy time and repositioning entails for them to have a fighting chance to treat this conservatively, limiting times in carriers, repositioning devices, and then other preventative repositioning strategies that are safe, for instance, specific pillows or positioning age. And of course, the importance of tummy time. And then the importance of early referral to a pediatric specialist, be that a chiropractor, an osteopath, or a pediatric physiotherapist. Specifically, if there's head or neck tightness or weakness issues, torticollis. If there's development delays, obviously early intervention is even more important. And if there's any form of cranial deformity, early intervention and referral to the pediatric specialist is included. And where I play a role, once we reach a age of 4 months, then a cranial orthosis is indicated. Unfortunately, most, if not all studies show that after 4 months of age, cranial head shapes really don't respond to anything as well as they respond to a cranial orthosis. It derives its name from its feature. It steers cranial growth. It's something that the baby wears for 3 months of age. It doesn't impede movement. It doesn't impede growth. It's custom made for the patient's age. And what it does is it repositions. By using the posterior side and the anterior side, we get correction in those areas according to the growth. We know the baby's on a certain percentile of growth. So if the deformity is scored at 4 months, if it's severe, or 5 or 6 or 8 months, we know what the growth percentage will be. The baby follows the same line of projection, that is translated into cubic centimeters. Those cubic centimeters are allocated in the correct areas to steer growth naturally to those areas. And by doing that, we have beautiful realignment of the sutures and the bones, which include not only the neurocranium, but the visceral cranium as well. Now, when to prioritize treatment, again, is if assessment indexes indicate more severe cases need to be treated earlier because our window of opportunity is shorter. If we have a very severe case, we often start as early as 4.5, 5 months. The more milder cases, we can wait for 6 months. Of course, we're looking at chronologic age. We're looking at delayed milestones. If the baby's hypertonic, we start a bit earlier. If there's any presenting torticollis still at age 4 or 5, early intervention is not only going to help with the head shape, it's also going to help with that torticollis presentation. And then also if an infant is not responding to repositioning, or if the parent has twins or triplets, they just don't have the time or the dedication for those repositioning strategies, then we implement the orthotic program earlier. Now, the misconceptions is that it will resolve itself. I think this is rather silly. If you look at the physiology of the actual cranium and you look at the growth and you look at the pathology, it's important, or it's impossible for it just to spontaneously correct. The pattern of early motor development is affected by the sleep position. We know that on average, supine liars attain common milestones later than prone liars. So now that prone is the position, now that supine is the position of choice, there's a 4 to 6 week delay. So maybe the old school therapists or practitioners did see some form of improvement. Now that the back to sleep program has been introduced, we're not getting the heads to correct because we're not getting those repositioning from the back lying position. Now, again, it is something that can be fixed in adulthood. There's a bunch of guys doing these cosmetic surgeries. These implants are done with very small incisions. Now, these incisions work well for the posterior side of the head, but again, they have little impact on the front of the face, nothing. And also, very importantly, the people aren't able to play a lot of active sports. Because as we know that a asymmetry and a cranial deformity on the posterior side of the head also affects the front. So it's definitely not something that only is presented on the back of the head and it's only cosmetic and will be covered with hair. It includes facial deformity, mandibular asymmetry. We get abnormal eye placement, not only in the sagittal plane, we see displacement. We see one eye a lot lower than the other eye. And we also get malalignment. We get orbital asymmetry, which results in strabism. And then also other issues, be that cosmetic. And again, when you're looking at the actual CT scans, you can see what it does. That can include, as I said, facial deformation. And here's a representation. So you can see that one element leads to a compensatory deformity and displacement in the other element. You can't anticipate that you're going to get such a severe asymmetry. And we get asymmetries that are 27, 30% all the time that have been told they're correct. You can't envisage that such a huge displacement on the back of the head isn't going to present itself on the front of the face and in the other structures of the cranium as well, including the actual processes and facet. And the same with brachycephaly. One of the people that often bring their patients early is the dentist. The dentists have a direct understanding. They're looking at heads all the time between malocclusion and brachycephaly and plagiocephaly. If you speak to a dentist, ask them what is the incidence that both these presentations are present, and it happens all the time that the malocclusion has a severe asymmetry or brachycephaly presentation. Now, early recognition is very important. We can't wait up to 16 months of age. In fact, even 12 months of age is incredibly late. if you're looking at the cranial growth, that's our window of opportunity to treat this. So as soon as that window of opportunity is finished, we are stuck. Now, they are not uncomfortable. We have hundreds of kids wearing these. They are proven, have a fantastic track record, and most insurance companies do cover cranial orthotics as long as the indexes are indicative that it needs treatment, both the CI and the CVAI index. These are the conventional orthotics. Now, these malalignments can affect other health outcomes. We as healthcare practitioners need to all work together to introduce a multidisciplinary care approach and take it from them. Now, I'll just 2 minutes go over a couple scans. As you can see here, this is actually a CT scan that's been rendered into a 3D model, and you can see the displacement. I have to frankly say I need to understand how other modalities treat these displacements. I treat it from a functional approach with a cranial orthosis, and you can look there at the posterior and the side, how it affects even the foramen, that magnum. And there we have it again. You can see the early development of the jaw, and then the displacement of the parietal and frontal bones. And this is a scan that's actually done of a 17-year-old, which is also interesting. This is an anatomical model that's been created. And again, there's hundreds of these scans available of positional plagiocephaly. And you can see how it affects not only the tiny foramen ovale, but also the spinosum foramen, and then of course the big magnum. Now, different disciplines think differently how this affects the cranial nerves. And then the front of the face, and I've got various scans that have been rendered. And that's the end of my presentation. If there's any questions, feel free to let me know. I'm available. Let me just close this. And thank you very much for your time and for being here and spending the evening with us. And thank you for the hosts, and thank you for my esteemed presenters that preempted this presentation. Thank you.
Thank you so much, Charl. It's always so nice to hear you speak about your in-depth knowledge, and then also to be so privileged to see you at work here at Hope. And I can vouch for you. We don't hear your baby scream, so I know you are very kind in your approach to these sensitive little creatures you work with. So thank you so much, Dr. Nageena, again. Like Charl said, very informative. Thank you, Charl. I would also, like you, Charl, I would like to thank the management of Hope, especially also our admin front office team. They did a lot of work to get this up and running for us. And I think we should do this again. Thank you so much for everybody who joined us, and I hope we all have a safe and restful evening ahead.
Thank you, everyone.
Is there any questions?
Thank you. Bye.